Welcome to the Expert Roundtable podcast, where we connect frontline clinicians with top thought leaders to facilitate discussion on key issues they face daily.
Welcome to Expert Perspectives podcast. These experts will provide their opinions, their insights, and their commentary on some leading topics and issues in medicine. And today we'll be specifically focusing on food allergies. And I'm honored to be joined today by Dr. Terry Brown Whitehorn, if you're able to introduce yourself.
Oh, thank you for having me. My name is Terry Brown Whitehorn. I am a pediatric allergist at Children's Hospital of Philadelphia. I've been involved in the field for over 20 years, and I see patients with food allergy, all different types, on an almost everyday basis.
Thank you. Dr. Ruchi Gupta.
Hi, I'm Ruchi. I am a professor of pediatrics at Northwestern and Lurie Children's, and I run the Center for Food Allergy and Asthma Research there. And I have a daughter with food allergies, and like Terry, been doing this for about 20 years. So it's everything I do, pretty much.
Thank you. And Dr. Edwin Kim.
Hi, I'm Edwin Kim, and I'm Chief of Pediatric Allergy here at the University of North Carolina School of Medicine, and I'm also Director of our UNC Food Allergy Initiative research group, and I've been involved in food allergy clinical trials and research for the last 12 plus years.
Thank you. Thank you again, all three of you, for joining us this afternoon. And I will go ahead and get started now with our first topic for discussion, and that is a discussion on the epidemiological trends and the prevalence of food allergies. And I wanted to talk with all three of you a little bit to learn more about some of the trends that you have observed over time regarding the landscape of food allergies. Are there certain populations that, in changes that you've seen in terms of being increased or decreased risk of developing food allergies over time, or of having more severe reactions? And for this topic, if we could start with Dr. Gupta.
So some things we've noticed are, again, across the board, but certain foods are higher in certain racial and ethnic groups. So we see shellfish, finfish higher in the Black population, sesame a little higher in the white population. Asians, we see some tree nuts. So it's interesting to, watch this and understand it, because it helps you counsel your patients a little bit better. What we see in low SES is they're spending a lot more on emergency department visits, a lot less on allergist visits, and less on special foods and on medications. And that makes sense, but how do we help support that so that we can get them proper diagnosis, get them the food they need, to stay safe?
We have very much been recommending and encouraging early introduction of peanut as well as other foods as a means of trying to prevent the food allergy from happening in the first place. And I guess the good news is it does seem like the message is getting out slowly but steadily, and more folks are trying to do this. But what that's actually meant for our clinic is we're seeing kids younger and younger with their first reactions to peanut as well. And so we've been getting patients that are 6-7 months old now with new reactions to peanut as well as some other foods. So that's one trend that we're trying to adjust to. And how do we manage patients who can't even sort of respond back to us and kind of tell us that they're not feeling well? Cashew seems to really be standing out amongst all the tree nuts as one that seems to be more prevalent. And then again, I don't want to overcall it, but it just has that feeling that people maybe are more sensitive to it. So reacting with lower IgEs and lower skin tests, and perhaps even having more significant reactions to it.
We've seen where we recommend to introduce peanut early to prevent IgE-mediated food allergy, there seems to be an uptick in those who develop delayed vomiting. We've also seen a bit more eosinophilic esophagitis, which, although it's a different mechanism, it can be related to food. So I've seen both of those things as well.
Our second topic was a discussion on the role of biomarkers in the management of food allergies. In this field, what biomarkers are currently being used clinically, either in diagnosis or management of food allergies, and your opinions on their prognostic or diagnostic value or significance, as well as what's coming down the pipeline in terms of biomarkers and what role that might have in the future of what we're looking at in terms of clinical care. And Dr. Kim, if you'd like to start with this one.
And I think that's the sort of the danger that we have right now, is that it's very easy to be able to order large panels of these tests, especially the blood tests. But again, without the proper without the proper interpretation, it runs that risk of overcalling allergy. And that has multiple effects, of course. One of them is unnecessary avoidance, but also in the world of these therapies that are coming online, it could have people getting therapy for things that they don't necessarily need to be on. And so it is definitely an area that's super important right now for us to be able to, just from the diagnostic point of view, improve on, so that we can better put the right people on treatment.
The other thing I wanted to reiterate, which both of my colleagues had mentioned, was the high false positive rate with food allergens and food testing that people sometimes do. And it's one thing to have a test in front of you and there's 10 things positive, but then when you can tell a family to remove 10 foods, or if they've never had the 10 foods, we have to keep in mind that the nutrition of a child is so important.
I think we're ready to move to our third topic. So this one is early oral immunotherapy as a curative treatment in food allergies. I wanted to have a bit of a discussion with all three of you about sort of the potential role or the potential benefit of early OIT in patients with food allergies, and a little bit of the nuance of what that might be, meaning are there specific food allergens which might be more responsive to considering early OIT than others? And then the third part of that is, could doing something like this early alter that immune response to elicit something that looks like a cure for patients?
I do think that the immune system early on is more adaptable. And I think that these therapies may be significantly more beneficial. We've seen it in some of the oral immunotherapy studies that we've done, that the younger the age group, it appears that they do better.
We definitely feel like we can get we can change the immune system, we can get longer lasting benefit. We're definitely making steps towards cure, but are we there yet is what we don't know. And I think I used the word remission as that impact study of 1 to 4-year-olds had started to use, but at the same time, I also used the word relapse. So anytime you use the word remission, I think relapses kind of go hand in hand. And so I share with the families that about 20% of patients that started that young were able to get this long-lasting sort of protection, but we don't know how long it would take for a relapse. Maybe it's multiple months or multiple years, which would be wonderful, but it could just be a little bit longer after that. Once we know earlier is probably better for multiple reasons, at the same time there are going to be some life factors, and trying to find that balance between the two to find the ideal early but ideal time for that particular family.
Okay, so final topic today is the discussion on novel therapies for food allergies and their potential role in patient care. And so I wanted to learn from all three of you a little bit more about the therapies that are coming forward for food allergies beyond, we've had a lot of discussion about OIT and its role, but perhaps beyond that, where it looks like the field may be moving, and what options we may be looking at in the future for patients with food allergies, including alternative delivery systems like SLIT, and the role of biologics and things of that sort. And what are the potential risks and benefits, and where might these different types of therapies play a role in patient care, as well as any other fields or therapeutic areas that may be considered in the future. I will open this up to whoever would like to start with this one.
There's not a one-size-fits-all in my mind, and so I think two directions that I think treatments are new treatments are headed. One of them is going to be treatments that are going to try to even more get that long-lasting kind of tolerance. So really get at the cellular immunity and see what we can do as far as inducing longer-lasting tolerance, even more than what we've seen, or more definitively than we've seen for oral immunotherapy. And these are mostly sort of biologic-type medications. And again, when we start talking about really altering the immune system, there's concerns, right? Rightfully so, and risks that come with those. But then there's also going to be another direction, is going to be that same desensitization we've seen, but can we do it easier? are there ways that it's less burdensome? It's not adding sort of extra work to families.
I do think that when we talk about oral immunotherapy or any of the therapies, what's important to know is that if you stop the therapy, then the benefit over time decreases for multiple people. So you can do whatever therapy for 3 years, and then if you stop it, part of the problem is if you haven't really, quote, outgrown your allergy, if you stop the therapy, and we don't 100% know the exact length of time, but let's say 6 months later, you have an exposure to that food, the child, even after spending 3 years doing something, could have lost the benefits.
Those are, we also know that different foods kids do outgrow and develop natural tolerance, and milk and egg are 2 of them, and we have ways to speed them up a little, with these milk and egg ladders. So small amounts of baked and then moving into regular. And I think those are really, really important because, it's the cakes and cookies and ice cream and all this stuff, that is just amazing for kids, but anyone, really. So I think we have made really good progress, and I think there's enough of that, research has been done where we do know that we can speed up potentially natural tolerance. So about half of kids with milk and egg allergies will outgrow them on their own compared to, peanut and tree nuts.
I do think that it's such a different mindset as opposed to like being relegated to avoidance. You don't have a choice. Now it actually is one of many choices. So you could potentially, if you have peanut allergies, seek out a few of these different treatments, or you can choose to take the avoidance route and wait for the next best thing. And so I think just more this proactive approach to food allergy is exciting to be part of. As opposed to sit back and kind of passively wait for something bad to happen, which is what we've done for many, many years.
Well, I think one of the biggest points that I've taken away from our discussion is that sort of the management of food allergies is truly an art, and so there is so much that is individualized to patients that those discussions with their patient and their families really matter because it will guide what happens next. And there isn't a one-size-fits-all in this field that when a patient walks in with X, you do Y. And so I think it's fascinating to learn from all of you about how important all of those nuances and considerations need to be.